Hello, dear colleagues. It's Conversations About Hearing. My name is Fatulin, and our today's guest is Marlene Bagatto, Assistant Professor, School of Communication Sciences and Disorders, Western University, Canada, the chair of the Canadian Infant Hearing Task Force that advocates for infant hearing healthcare across the country, one of the authors of Ontario Infant Hearing Program Screening Protocol, Surveillance Protocol, ABR Protocol, and Pediatric Amplification Protocol. Through these activities, Professor Bagatto consults for various provincial early hearing loss detection and intervention programs in Canada to develop and implement clinical protocols and program policies. Hello, Marlene.
Hello, how are you?
Fine, thank you for accepting my invitation, and from the name of Russian audiologists, thank you for your protocols because we use them, we follow them.
I'm very happy to hear that. Thank you. Yeah.
The first question about the DSL method, how it was developed, what are the aims of this method, and does it suit for children only?
So the DSL method, desired sensation level method, was originally, the first version was developed in the 1980s by my colleague and mentor, Dr. Richard Seawald. And he found that in the early 1970s, when he was working in Nova Scotia, Canada, that there was a rubella outbreak among people there, and babies were being born with hearing loss. And at the time, there was no way to consider how we would fit hearing aids on children who were born with hearing loss. So he went back to school and developed the DSL method, which aims to provide clear, consistent access to speech at safe levels across a broad bandwidth. And it's gone through several iterations. We're on DSL version 5 now. We try to continue to update it. So my colleague at Western University, Dr. Susan Scully, she leads the continued development of the algorithm, which is licensed to different hearing aid companies and manufacturers of hearing aid test systems, so we can have it as clinicians to use regularly. And we make sure that it aligns with current hearing aid technologies. And in 2005, we added a prescription that's more suitable for adults who have acquired hearing loss, because we know that children born with hearing loss have different listening needs than adults who already know language and acquire hearing loss later in life.
So can we expect DSL version 6?
Hopefully. We are currently, you may have learned that we have a set of bone conduction targets that are for percutaneous bone conduction device fittings in adults. And we're currently working on, I don't know if we would call it version 6 at this point, but we're working on having targets that are suitable for bone conduction devices that are skin worn or transcutaneous. So I think there's like this other separate prescription for bone conduction devices, but I would hope that a version 6 will come in the future.
Okay, let's talk about the minimal and mild hearing loss in children. When would you recommend an initial amplification if we diagnosed it in infant? And are hearing aids indicated in each case? What are the indications and amplification strategy?
Oh, great question. So I think for those of us who are pediatric audiologists, finding a mild hearing loss in a baby, which is commonly done through frequency-specific ABR, can be a challenging management scenario, because babies are closer to the parents. They can access speech sometimes without hearing aids. They're in quiet environments. They're not in school yet, where they are going to have some challenges hearing the teacher in noisy and reverberant classrooms. So in terms of an infant, we need to consider the readiness of the family to proceed with mild hearing loss. I think we also need to consider the configuration. So sometimes it's a flat configuration, and sometimes it's normal in the low frequencies and a mild loss in the high frequencies. So in that regard, infants and young children, we don't have the opportunity to put a vent in the ear mold to ensure that we're not plugging up the low frequencies. So I'm listing lots of factors without saying that they are factors. And the other thing that I would add is our assessment techniques for babies, we can only go so low. So with ABR, we get inherent noise, and we're often only testing to 20 or 25 decibels in EHL or HL, and that's the same for behavioral testing or VRA. And children under 3 don't really respond at threshold all the time. So it could be that it's better than 20 or 25, and that matters for the fitting as well. So there's some challenges there that are just inherent and probably won't be able to change much, because babies are always going to be babies. I would add that it helps us to consider ear canal acoustics and transform those HL values from our assessment to sound pressure level. So measuring an RECD and applying that in that DSL method will help us understand the exact sound pressure levels that the child will require if they were to have a hearing aid fitted. And it allows us to see how much gain will even be necessary within the hearing aid. Do they have access to the speech signal in the unaided condition? Recently, around 2020, Ryan McCreary from Boys Town did some work looking at the speech intelligibility index in the unaided condition, and how children with mild hearing loss would perform on language measures compared to their normal hearing peers. And if their SII value was roughly 80 or better, if they had mild hearing loss, and in the unaided condition, their speech intelligibility was 80 or more, then they were performing similar to their normal hearing peers. So that's another indicator that we can use, in addition to all of those other factors like family readiness. Ear canal acoustics are needed to determine the sound speech intelligibility index, and just where the situation the baby is in, and things like that. So I would add that the protocol that you mentioned, the amplification protocol that we have in Ontario, that it outlines all of those factors for you in a specific addendum related to managing children with mild hearing loss, because it's a tough one.
Yeah. Marlene, it's very interesting to know about your experience with unilateral hearing loss in children. If it's aidable from mild to moderately severe degrees, it's quite clear. However, what if there is a severe or profound unilateral loss? Are there some specific insights in hearing aid fitting? How to evaluate outcomes? Which indicators should we take into account?
Mm-hmm. So again, another challenging scenario. So again, in our protocol, we spent some time addressing this particular situation. And one important factor for children with severe to profound unilateral hearing loss is to see and get some imaging results, because about 50 to 60% of children with that degree of loss in the affected ear may have some cochlear nerve deficiency, which helps us understand sort of the impact of any sort of technology that we might recommend. Hearing aids, as you mentioned, are not typically the recommendation, because there's going to be crossover to the normal hearing ear. We can't measure it at this point. I know some people are sort of looking at how we might consider that, but even the power available in hearing aids for that degree of loss would not give us the audibility that we need. I know in North America, cochlear implants are a technology that is now available for children with profound unilateral hearing loss. Again, but the nerve needs to be properly formed in order for that to happen. We conducted a scoping review that also showed that remote mics can be suitable to help with children where the affected ear can't necessarily be supported by other technology. When the child is older and able to manage their listening situation better, a cross system could be suitable. What we're trying to avoid is blocking the normal hearing ear, so that ear needs to be open and the child needs to be aware of their surroundings so they're not getting noise filtered just to the good ear. And a bone conduction device will support that situation as well, and it doesn't occlude the normal hearing ear. I would like to also share, and you'll see this in our protocol, that this, and thank you for calling it a severe to profound unilateral hearing loss. A historical term, or we like to think of it as historical now, is single-sided deafness. So what we're trying to know is, can that ear accept sound? And the imaging helps with that, but Erin Cuckoo, our colleague at Vanderbilt, she's been doing some work with cross devices in children, and she developed a term that we have adopted called limited usable hearing unilaterally. So although the audiogram shows, you know, some thresholds, we don't know what the speech perception abilities and the integrity of the nerve are, and it's hard to measure that in very young babies. And in some places, like where I live, imaging isn't always timely. So we do have to consider some technology recommendations to the family in the absence of that information. So that's also a consideration and makes the management of these children complex, but we've tried to provide some guidance in our addendum as well.
Yeah. Some hearing clinics owners say, I don't understand what the benefit of the verification system is. It's expensive, but we can sell hearing aids without it. Only have an audiometer and hyper, for example. What would you answer them? Does an objective verification really matter?
So I think you would expect my answer to be yes, but I believe and I've experienced the benefit of using these systems for both infants and for adults. So by placing a hearing aid either in the patient's ear or in a test box and measuring the output of that device, it allows you, first of all, a type of quality assurance. You're seeing that the device is actually providing output. And back to our DSL question and the fact that we transfer the targets and the algorithm within these hearing aid test systems, we are able to see those targets on the screen. They have been calculated for that individual's hearing loss, and then through these test systems, we can measure exactly the sound pressure level at the eardrum and align it with those prescriptive targets. And by using either the now prescriptive formula or DSL, which is they're both generic, so they're not product specific, then that means that we are giving the same validated treatment to our patients across the board. It's individualized by their hearing loss and their ear canal acoustics. But if we're only using a computer and not measuring the output of the hearing aid and potentially using a non-validated manufacturer-specific prescriptive formula, we're not actually providing similar interventions that are evidence-based, and it doesn't allow us to compare outcomes across patients either. So there's a lot of benefits to doing it that way. If a verification system is not available, I will add that any sort of outcome measure that you can do and have that consistent would be helpful. And if you're using software from a computer, most of the hearing aid manufacturers have licensed DSL or NAL. And I can speak for DSL that we make sure that the implementation of DSL is accurate as it's appearing on the screen. But again, what that's not allowing you to do is measure that individual device's output. And it's for safety of that the listener using the hearing aid as well. And in particular for infants and the aging population who can't really interact with the process of verification and tell you things, it's really critical for us to objectively measure these medical devices and make sure they're safe and providing the right levels of sound.
But from your point of view, can the an objective verification be replaced by some other methods if the clinic doesn't have a verification system still? For example, in situ audiogram or aided thresholds?
Those are typically used for validation. So a threshold is just that. It's the softest level that somebody can hear while wearing the hearing aids. So it doesn't tell you about the levels of speech and the maximum power output of the hearing aid, which is what that auditory range will give you in the hearing aid test system. So in my experience, I don't believe that those things can replace it, but they might be a way to ensure that you're getting some audibility, but you would need to do some super threshold testing to see if they're getting access to speech rather than just hearing a soft level, because they don't transfer exactly the same. And we want to make sure that the power output of the hearing aid is not too high to cause discomfort or damage, and not too low to cut off any sort of louder sounds that the individual would need to hear in their environment. So if it's possible to even get one system for a clinic that people can share, that would be ideal.
Okay. If you don't mind, I will attach the Ontario Pediatric Amplification Protocol to this video for our colleagues. And in this protocol, RECD and coupler verification procedures for infants are described. There is one more way to measure REUG and verify in the real ear. Are there some differences in results between these two strategies? And is it possible to verify in coupler for older children and adults?
So the REUR would be used if you're verifying using insertion gain, which assumes an average adult ear, which babies especially do not have, and a lot of average adults don't have it either. So the way that the RECD and in situ real ear verification is being conducted is to measure the actual aided response versus the amount of gain that you're getting from the hearing aid by simply inserting it. So we haven't used insertion gain for many years, like since DSL has never used an insertion gain approach, which is what the REUR measurement is for. The RECD does involve putting a probe tube in the ear, like an REUR would allow. The difference would be, especially in babies, the REUR, you need to be very still and quiet in the environment for that to be accurate and get a clean measurement. But the RECD, we're putting the child's ear mold in and it's occluding it. They can move around and it's not as affected by noise in the environment or just sounds in the environment. So it is definitely possible to verify in the coupler for children and adults. And the RECD allows us to individualize that coupler verification, which is essentially a simulation of the real ear aided response. So by measuring the RECD, you're transforming the HL to SPL values, like I talked about in the mild hearing loss question, and then it allows us to transform from the real ear to the coupler. And we do it with adults all the time. It allows us to do sort of a pre-fitting. And again, back to the quality assurance, we can check that the device is functioning properly, make the adjustments we need to, set up a variety of listening programs. And then when the patient, the adult, comes in for their fitting, it's pre-programmed. We do a hearing aid orientation, and then we can make any adjustments we need to, and we can look at that baseline, those baseline measurements we have from our output.
There are some additional procedures of verification, different functions like frequency lowering, noise reduction, directionality. Should we verify them each time or in case of some complaints?
So definitely frequency lowering requires some individual adjustments. So I know that there are default settings for that technology in the fitting software, but again, in our protocol, we've refined the verification of where that and the strength of that frequency lowering should be. Because what we don't want to do is have it too strong, because then the high frequency phonemes will be confused by the listener, so S and SH. And if it's too weak, then it's not going to be providing the audibility that is necessary for the frequency lowering to begin with. So the default settings sometimes are not in the proper range of the person's thresholds. So we try to maximize that by fine tuning it. So we get it started and then we fine tune it. And then for noise reduction, essentially we'll probably do that like the first time it's turned on, because we want to see, again, both of these are reasons to have a verification system, because we then can measure the strength of the frequency lowering and the audibility and what it's doing. But for noise reduction, we can deliver different noise sounds to the hearing aid and measure exactly how much it's reducing the noise. And within the fitting software, we can change the strength of it based on what the patient is reporting or the family is reporting for us. Often the noise reduction, if the setting is fine, we won't have to verify it every single time if we know how it's working. But frequency lowering, we'll keep checking it because we're going to keep checking their thresholds. And it matters where your thresholds and your canal acoustics are. So, yeah.
Marlene, how to verify the bone conduction hearing aids?
Yeah, that's a good one. So this is a very new area that I've been working on with my colleague Susan Scully and our colleague in Alberta, Bill Hodgetts and Alex Gascon. So recent advances, so I mentioned there's targets for percutaneous devices. And so along with that, there is available a skull simulator to go with your real ear verification system. So rather than verifying, as has been in the past, using aided audiograms, we can now place the bone conduction device on a skull simulator. It has an abutment like one would wear. And then we can again put it in the test box and verify it to the DSL bone conduction targets. So once you have a skull simulator, you would just do the same verification procedures with speech and maximum force level output, because these are measured in force level, and you see a force level ogram versus a speech ogram. The other thing that is recommended, and again, this is a section in the protocol for children. Children are often wearing those devices on a soft headband and skin worn because they can't have the surgery until they're 5 years of age, around here anyways. So we want to account for the loss of force that occurs through the skin. So we call that skin transmission loss. So one thing that we recommend for those devices is to even though we already have their audiogram, a lot of children have atresia or microtia, so we have their bone conduction audiometric thresholds. What we know is that those audiometric thresholds in bone are different from the thresholds we would gather with the bone conduction hearing device, because it's a speech processor and not an audiometric transducer. So we need to then do in situ thresholds with the bone conduction hearing aid itself, and then use that to verify the device to account for the individual's skin transmission loss. So it's kind of like a bone conduction version of an RECD. So we need to individualize what's happening for their individual head and skin thickness and skull. And so we have a child, so we have to wait for the child to be able to do VRA with their bone conduction device on, and then we enter those in situ thresholds into the verification system, snap the device onto the skull simulator and verify it that way. And again, that's all in our protocol too.
What are your recommendations for fitting hearing aids in bimodal cases with CI on the contralateral ear?
Oh, I wish I had more of a response than I'm about to share. I have not been able to find a procedure that we could put in our protocol that allows for anything different for a bimodal fitting. At this point, my understanding is we would fit that hearing aid the same way that we would if it was a hearing aid without a cochlear implant on the other side. My question to my cochlear implant colleagues has often been, you know, how do we balance those devices? And is there a procedure we can use to balance those devices? And it might not be this way where you are, but where I am, often audiologists are either working with hearing aids or they're working with cochlear implants. And we sort of stay in those different areas. And I do have these questions that I just shared, and, you know, I'm guilty of it too. And I think that, you know, we need to come together, and potentially the cochlear implant groups have a procedure that I'm unaware of. But at this point, the hearing aid should be fitted, you know, to this using the same procedures we've been discussing. And if there's a balancing procedure that you have to, or there's a way that the patient can tell you, you know, adjust this and that, then I think that's an extra step. I don't have a good understanding of a specific protocol for that yet. So I think that's an area that we need further development in for sure.
Yeah, but particularly, would you recommend switch the frequency lowering off in these cases?
No, I would still, yeah, I still would do what is necessary for that. So we often just fit ears as ears, right? So a single ear, and I would still apply what is needed. And again, step back and say, so how does the whole system sound? And then you can choose to turn it off or on. So yeah, I think it all is part of the same situation.
The sound sensation will be mixed in the head anyway.
Yeah, so if you fit that hearing aid and you use the procedures and they say, yeah, I don't like frequency lowering, then turn it off or whatever. So they have a whole system, but we do have to fit each one individually first. And then my question is around, so what happens when you have the whole system on? I'm not sure exactly how people are approaching that. So, yeah.
There is a trend of spreading receiver in canal hearing aids rather than other types in the last years. Many children and parents ask about less visible hearing aids. From your point of view, is it reasonable using other types besides BTE in children?
I would say if it's suitable for the child's hearing loss. So we know that there are limitations in the amount of power these devices can provide compared to power BTE hearing aids, which many children need. And in order to wear those without feedback, you need a full shell ear mold. The other consideration is around retention. So very few infants and young children are wearing these devices because they're just not going to stay in their ear. We already have retention issues with young babies and toddlers. They're pulling them out or whatnot. They're pretty active. So my understanding is people might start to provide these devices if they're appropriate audiometrically when children are like 8 or 9 years of age. So it's not unusual, but certainly those two main considerations are important.
Marlene, if we talk about the trial amplification period before cochlear implantation in children with severe and profound hearing loss, Should we fit hearing aid according to the target, or it's possible to increase gain up to maximum to reach lower aided thresholds?
I think it would be suitable to fit them to the DSL targets because they're accounting for the degree of hearing loss and also safety. And we want to ensure that, the volumes are appropriate. We're working with a much smaller dynamic range. So there's limits to what the hearing aid can do and what the child will tolerate. In terms of aided thresholds, I think that I'm guessing that cochlear implant programs have different criteria for what those aided thresholds should be. And they also expand performance, because that's what an aided threshold is, to speech perception thresholds and their performance on that. So again, I think that would be the purview of the cochlear implant program and their evaluation process. But certainly we have a very small dynamic range to work with. And a 1 dB adjustment will probably make a big difference, either positively or negatively. So I definitely would start with the target, but you're not going to be able really to go much beyond that. But it's worth trying, because the benefit or not that the child receives from the devices really impacts the decision around getting cochlear implants, at least where I am.
And again, we need the verification system.
Yes. Oh, that's another great reason, because we're talking like very small changes from the fitting software and seeing where that aligns with the target. So again, that's another great reason to have a verification system when we're working with these extra challenging cases.
Professor, and my last question is a bit tricky. Do you believe that the highest level and the most expensive hearing aids always the best choice for children? How audiologists can figure out with marketing promises and real clinical needs? What's the minimum number of channels needed for pediatric patients?
So I don't know that the children need the premium versions. I think my understanding is the different levels of hearing aids within the same sort of model, model. They have more sophisticated sometimes noise reduction algorithms and things like that, and more channels, as you're indicating. So it gives increased flexibility to the adjustments of the hearing aid. I think, an 8-channel hearing aid is fine. The evidence doesn't support any benefit beyond roughly that. And also the evidence in the different noise reduction algorithms, those are specific to the different manufacturers. So we often are using sort of a base or a mid-level device. And if you look at some of the companies that are invested in pediatric hearing aids, and the pediatric audiologists listening to this will know that either a company is aligned with the needs of pediatrics or they're not. And there's not very many that align with pediatrics. And even within those models, they don't have a really high-end product, because the evidence doesn't suggest that it's going to improve outcomes for children, and families, are not necessarily equipped to pay the extra funds for devices that may not result in improved outcomes for their child. The key factors that we need is that the hearing aid provide good, safe, comfortable speech access, and the DSL method helps with that. And we want the child to wear the hearing aids as much as possible during the day. So any way that we can support families in doing that is really critical. And then they need that spoken language access as well. So I don't think it's not to be, to answer the question. I don't believe the highest level is necessary. And I think clinical needs are something that the audiologist or the person fitting the hearing aid is something that we need to decide by talking to our manufacturer reps. And I think I answered the other question. So, yeah.
So Marlene, thank you so much for sharing your experience. It was very interesting, and thank you for your time.
Thank you very much. It was my pleasure.